Welcome to Roadmap to Residency. Hello everyone, I'm Abhiraz. Welcome to our Club 250 Mass Maker sessions. We are currently in our nephrology module and we will be running through some questions with you guys to help you on a journey to a 250. So, which of the following is the most likely cause of acute kidney injury in this patient? A 50-year-old man with a history of hypertension and a type 2 diabetes is admitted to the hospital for septic shock secondary to proteinuria. Secondary to pneumonia, sorry. He receives aggressive fluid resuscitation and broad-spectrum antibiotics. During the hospital stay, his urine output decreases and lab tests reveal a rise in the serum creatinine. The patient's clinical history includes the use of NSAIDs for chronic knee pain. On examination, he is hypotensive with dry mucous membranes and reduced skin turgor. Which of the following is the most likely cause of the acute kidney injury in this patient? Obstructive uropathy, glomerulonephritis, minimal change disease, acute tubular necrosis, or membranous nephropathy. Acute tubular necrosis. The patient's history of septic shock, aggressive fluid resuscitation, and the use of NSAIDs for chronic pain, knee pain are risk factors for the development of acute tubular necrosis. Acute tubular necrosis is the common cause of acute kidney injury in hospitalized patients and is characterized by the renal tubular cell injury and necrosis. Obstructive uropathy can cause AKI, but the clinical scenario with septic shock and NSAID use is more suggestive of ATN. Glomerulonephritis is less likely in the setting of septic shock and is not associated with NSAID use. Minimal change disease typically presents with nephrotic syndrome, not acute kidney injury in the context of septic shock. Membranous nephropathy is less likely in this clinical scenario, and it is not typically associated with acute tubular injury. Now let's talk about the acute tubular necrosis. So the most common cause of acute kidney injury in hospitalized patient is acute tubular necrosis. It is spontaneously resolves in many cases, but can be fatal, and especially during the initial oliguric phase. There is inclusion in the fractional excretion of sodium, and the key finding include granular cast, which is often muddy brown in appearance. You can see here, this is the muddy brown cast. There are three stages: the inciting event, and then after that there is the maintenance phase. For example, the inciting event may be hypovolemia, and after that there is the maintenance phase, where there is oliguria, which lasts for 1 to 3 weeks. Risk of hyperkalemia, metabolic acidosis, and uremia is present in the maintenance phase. And there is the recovery phase after that, which is polyuric, where the BUN and serum creatinine fall, and there is risk of hyperkalemia and renal wasting for the electrolytes and minerals. It can be caused by ischemic or nephrotoxic injury. Now, if it is ischemic, which is secondary to the decreased renal blood flow or pre-renal azotemia, now it results in the death of the tubular cells that may slough off into the tubular lumen. You can see here the sloughing into the tubular lumen. In case of nephrotoxicity, which is secondary to the injury resulting from toxic substances like aminoglycosides, radiocontrast agent, so there can be contrast-induced nephropathy, lead, cisplastid, ethylene glycol, myoglobinuria, rhabdomyolysis, hemoglobinuria. These all can cause nephrotoxic acute tubular necrosis. The PTs are particularly susceptible to, or the proximal tubules are particularly susceptible to injury in case of nephrotoxic, or you can say contrast-induced nephropathy. So which of the following is the most likely cause of renal findings in this patient? 35-year-old man or old woman presents to the emergency department with a 1-week history of fever, rash, and arthralgia. She reports taking a newly prescribed medication for the urinary tract infection. On examination, she has a maculopapular rash involving her trunk and extremities. Lab tests show eosinophilia, and there is increased blood urea nitrogen and serum creatinine. Urine analysis reveals white blood cell cast and eosinophils, and the patient denies any recent illness or changes in the dietary habits. Now, which of the following is the most likely cause of the renal findings in this patient? Minimal change disease, focal segmental glomerulosclerosis, acute tubular necrosis, interstitial nephritis, or membranous nephropathy. Now, the patient's presentation with fever, rash, arthralgia, eosinophilia, and the use of a newly prescribed medication is highly suggestive of drug-induced interstitial nephritis. Now, this condition is characterized by the inflammation of the renal interstitium, leading to the elevated BUN, serum creatinine, and urine analysis findings such as white blood cell cast and eosinophil. The minimal change disease is not associated with fever, rash, or eosinophilia. The focal segmental glomerulosclerosis does not typically present with eosinophilia or drug-induced features. Acute liver necrosis. While ATN can be associated with drug-induced kidney injury, the presence of fever, rash, and eosinophilia is more suggestive of interstitial nephritis. Membranous nephropathy. Membranous nephropathy is not typically associated with the clinical features of interstitial nephritis, which is seen in this case. Now, talking about acute interstitial nephritis, also called as the tubulointerstitial nephritis, there is acute interstitial renal inflammation, which can cause pyuria and azotemia, occurring after administration of drugs that act as haptens, inducing hypersensitivity. The drugs may be diuretics, NSAIDs, penicillin derivatives, proton pump inhibitors, rifampin, quinolones, and sulfonamides. Less commonly, it may be secondary to some infections like mycoplasma and some autoimmune diseases like SLE. It can be associated with fever, rash, polyuria, hematuria, and costovertebral angle tenderness. And in some cases, it may be asymptomatic. So remember 5 P's for the acute interstitial nephritis: P, diuretics, pain-free NSAIDs, penicillins, proton pump inhibitors, rifampin, and sulfide drugs. So 5 P's. Now, talking about the urinary tract infection. So infection of the urothelium of urinary tract is more common in women than in men and most frequently occurs in the early adult life, 16 to 25 years. And majority is caused by the E. coli, with a smaller percentage caused by the other gram-negative bacilli or Staphylococcus saprophytes. Symptoms may be dysuria, increased urinary frequency, suprapubic pain. There may be change in the urine color, odor, or hematuria. The elderly may present atypically with altered mental status or incontinence. Now, diagnosis is mainly by through the clinical diagnosis based on the symptoms and other supportive data such as urine analysis with pyuria, leukocyte esterase, nitrite can be done. Urine culture with more than equal to 10 to the power of 5 coronary forming units is suggestive of UTI. Note, in men, acute prostatitis can mimic the UTI. Digital rectal examination helps distinguish the conditions and reveals the edematous tender prostate in prostatitis. Epididymitis also may be confused with UTI. So management is by TMP-SMX and nitrofurantoin, which are the first line with fluoroquinolones or macrolides as the second option. Duration of treatment depends on the antibiotic use and also stratified by the uncomplicated or complicated um, pattern. Now, frequently extended duration to 7 days if complicated. Okay. Um, Acute prostatitis case, we use TMP-SMX is the treatment as the treatment of the choice, and we use it for 4 to 6 weeks. But in case of epididymitis, we often, due to the gonorrhea, chlamydia, and younger sexually active men, we treat it with ceftriaxone plus doxycycline or azithromycin. Now, in older men or men who are not sexually active, it's more likely to be 2 by 2 E. coli, and we treat it with fluoroquinolone. So, which of the following is the most likely diagnosis for the patient's symptoms and lab findings? A 28-year-old woman presents to the clinic with complaints of fever, dysuria, and flank pain for the past 3 days. She also notes increased frequency and urgency of urination. The patient has a history of a recurrent urinary tract infection and is sexually active. On examination, she has costovertebral angle tenderness. Urine analysis reveals pyuria and bacteriuria. Blood tests show an elevated white blood cell count, and mildly elevated serum creatinine. Now, which of the following is the most likely diagnosis for the patient's symptoms and lab findings? Acute interstitial nephritis, minimal change disease, FSGS, ATN, or acute pyelonephritis. So the patient's presentation of fever, dysuria, flank pain, and urinary symptoms, along with physical examination findings of costovertebral angle tenderness and lab results show pyuria and bacteriuria, which are consistent with acute pyelonephritis. Elevated white blood cell count and mildly elevated serum creatinine may also be seen in this condition. So pyelonephritis is caused by the same bacteria as those responsible for causing UTI. So it presents with flank pain or fever, and patients have low urinary tract symptoms that sometimes occur 1 to 2 days before the upper urinary tract symptoms appear. Now, they may also have nausea, vomiting, diarrhea, or maybe systemically ill. The examination reveals fever, costovertebral angle tenderness, and mild abdominal tenderness. Urine analysis shows pyuria and bacteriuria and may also exhibit hematuria. CBC reveals leukocytosis with left shift, and urine culture is usually positive, and blood culture may be positive as well in case of septicemia. Now, imaging is not required to make a diagnosis of pyelonephritis, but it may be useful in certain patients with at high risk of complications. Similar antibiotics to cystitis treatment, but course is longer. Empiric treatments utilizes either IV cephalosporin or IV fluoroquinolone. We do not use nitrofurantoin as this antibiotic cannot penetrate the upper urinary tract. It's a very important concept out there. The complications of pyelonephritis include renal strobitis stones, peripheral abscess, and intrarenal abscesses. Thank you for watching. Keep studying.